Okay, so I wanted to share some interesting statistics. So 500 people surveyed, 62% didn't know the signs and symptoms of stroke, 27% didn't know to call 911, 36% didn't know that you can actually reduce your risk of having a stroke, 46% didn't know that the emergency treatment for stroke exists, and 52% did not call 911 when they were actually in a stroke emergency, and only 1% of people nationally actually believe that stroke is a major health problem. So, with all of this, stroke is becoming a larger epidemic in the U.S. with 795,000 cases and 245,000 deaths each year, making it the fourth leading cause of death according to the National Institute of Health. Combined with how time-sensitive stroke care, and as you've seen in the large public belief that nothing can be done medically, there is a growing need for the education of the public on what stroke is, how to identify it, what will be done about it, and what the risk factors for stroke are. So what exactly is stroke? So there's two different types of stroke. There's hemorrhagic and there's ischemic. So the first type, hemorrhagic, is the most dangerous type, and it also depends on what it's caused by and where it is in the brain. So there's subarachnoid, or subdural, which is between your brain and your skull, and that's generally caused by either an aneurysm, which is a blood vessel that blows and it causes bleeding, or somebody who falls and maybe is on blood thinners or is an older person, and then the blood builds up. And then there's an intracranial, which is actually inside the brain tissue, and that can be also caused by an aneurysm. So what makes hemorrhagic strokes a really big deal is there's not too much that can be done about it, except to relieve the pressure. And what happens is so much blood builds up that the pressure builds up and it starts blocking off blood vessels. And then if there's no blood, there's no oxygen, there's no glucose, which is what actually feeds your brain, and so your tissue starts to die. And then the ischemic stroke. And these are the most common, and there's embolic and thrombotic. And ischemic strokes basically work on the same thing. So with embolic, you have a blood clot or a piece of plaque or vegetation or something that actually goes up through your arteries, and it lodges itself in a artery or vein or something, and then you're not getting blood flow to the area of the brain, and so then the tissue starts to die. And then there's thrombotic, which generally happens in the carotid artery in the bifurcation, which is kind of up here, and it's where plaque just sort of builds up over time, and it's more of a slower type onset, and then it builds up, and then there's no blood flow, and then you have a stroke. And then the last type that's kind of like a stroke, but I want to discuss it, was a TIA, which is a trans-ischemic attack, or sometimes called a mini-stroke. What's important about these is that a third of patients who have a TIA actually end up with a stroke. So TIA is basically a trans-ischemic attack. So it's a short-term stroke. So generally your symptoms resolve in about 24 hours, and there's no long-term deficits. It's just a short amount of time where there's no oxygen or blood going to your brain. So how would you identify a stroke? So there's two different ways that healthcare providers use to teach the public. And the first one is Give Me 5, which is 5 different things. There's walk, talk, reach, see, and feel. So with walk, you're going to see a lot of gait disturbances with stroke patients because there's a lot of weakness on, so if it's right side, it's the left side of a brain, it's opposite. So whichever side of their brain is affected, they're going to have a lot of weakness on. And so they might have posturing, which is kind of where they fall towards the side. And so that's what you have with the walk. And you can have them try to walk in a straight line. There's also things called ataxia and things that are a little bit more in depth. And then there's talk, which they can have slurred speech. They might not be able to understand speech, or they might not be able to talk. And then there's the physicality part of it, where if they have a droopy face, it's really hard to talk when your face is like this. And you'll kind of see that. And if it's very minimal, you can always have them smile or take out their tongue. And if it's dropped on one side, then that's a really big indication that something's really going on. And then there's reach. which is part of the arm drop test. So you have them reach out, and if one of their arms starts to drop, then something's going on. And then there's C. A lot of times with stroke patients, they might have a blind spot or not be able to see, or might not be able to see at all. And then feel. And this part is about the headache. So with the hemorrhagic strokes, like your subdural and any sort of aneurysm that blows, which generally occurs in the younger crowd, people under 40, you're going to have the worst severe headache of your life. And that's a really big indicator of a blown aneurysm. And then my favorite actual one is ACT FAST. And this is an acronym, and it kind of, says a lot about, how important time is. So you have FACE, which is the drooping face, arm drop test, speech, where you have the, slurred speech, and time. So what's really big about time is, so the big clot busting drug they use called TPA, it has a time limit. So it's a 3 to 4.5 hours from the time of onset. And that's the time of last known normal. So if you went to bed and you were fine, but you woke up and you had stroke symptoms, then you would go with the time you went to bed, because that's your last known normal. And even if your stroke symptoms didn't actually happen then, we can't know if it was at 2 o'clock in the morning or at 3. So we're going with your last known normal, which was the time you went to bed. So what exactly will happen in the hospital? So you'll go in to, the emergency room, and they'll do a stroke scale, which will be a long, in-depth stroke scale. You'll have, they'll test for weakness, the face, any sort of mental deficits or anything like that, and they'll come up with a score, and based on that score, they'll proceed from there. And if you have no stroke symptoms, then they're probably not going to proceed with that. But then they'll send you to CT, which is a just imaging of your brain, and they'll be able to tell whether it's hemorrhagic or ischemic, and that's where your big treatment differences lie. So if it's an ischemic, then they can do TPA if you're within the hour rule, or if you don't have any risk of bleeding, like if you've had a surgery recently or something like that. Or they can do a surgical removal, which they can go in with like a Mercy retriever and take out the clot itself. Or if you're not a candidate for any of those, then they can actually give you some less powerful clot busting drugs. And then if it's a hemorrhagic, if it's an aneurysm, they'll go in and they'll clip the aneurysm or coil it or something, or treat the underlying cause. Or if it's just from a fall, then they can do a craniotomy or a burr hole or something to reduce the pressure in your brain. So what are your risk factors? So there's 2 different types of risk factors. There's modifiable and unmodifiable. So your unmodifiable is stuff you really can't change. So that's your age. The older you get, the higher your risk of. I think it's older than 55. Each decade, your risk for stroke doubles. Your sex. Males get strokes more often than women, but women die more from strokes. Race, African Americans have a higher risk of strokes, and they also have a higher mortality rate. And then family history, and that can include not just stroke, but any sort of blood clots or anything like a heart attack or a pulmonary embolism. So your modifiable is the stuff you can change. So that's hypertension, coronary artery disease, congestive heart failure, and AFib. So if you have anything wrong with your heart, and hypertension is high blood pressure, coronary artery disease is just a plaque that builds up in your heart, and that generally leads to a heart attack. And basically all those plaque, and that's they can go towards your brain, and that's what we were talking about with the embolic strokes. AFib is where your heart just has an abnormal rhythm, and a lot of times with AFib, they have a really high risk of blood clots, which can travel to your brain. Smoking. Any sort of nicotine use, it doesn't matter if it's vaping or chewing tobacco or anything like that. Nicotine in and of itself narrows your blood vessels. So something that might normally pass by wouldn't, because your blood vessels are narrower, so it produces a higher risk. Obesity, bad diet, exercise, anything like that increases your lipids, or kind of the fat in your blood, which, puts plaque on your artery walls, which can include in your brain, which is, the thrombotic stroke, or it can have one travel up. Drug abuse, you can get an infection in your heart from drug abuse, IV drug abuse, and it produces vegetation on the valves, which can travel up and be an embolic stroke. And then sleep apnea, because obviously if you aren't getting oxygen, you're going to have issues with your brain, because your brain needs a lot of oxygen. So, with this information I've provided you, I hope you'll have a better idea of what stroke is and the different causes, and to be able to identify a stroke or a suspected stroke so you can act quickly, because it's just really important with strokes. And finally, so you can reduce your risk factors of having a stroke, or let your loved ones know and how the ways that they can reduce their risk factors.